Okay, so it's going to be a practical guide to medications. In the series of lectures, I'm going to go through everything that I'd want to know as a junior doctor or intern or medical student, really practical stuff. And let's get started. Ground rules are, look, my basic assumption about all of you guys is that, you want to do your best for your patients and for, I guess the well-being of yourselves and others. So, I'm going to ask lots of questions and I really want you just to offer answers. I don't care how stupid they are. Just remember that, failure, repeated failure is really just the path to success. So, might as well get that stuff out now, because trust me, it's a lot harder to be wrong psychologically when you're a consultant. And then there's also the ABCs of Anesthesia course. Just for your first 6 months of anesthetics, I run a kind of a day course for that. My website is that one there, anesthesiacollective.com. And me and a mate of mine, Stan, who's like this guru of first part knowledge, have also started this Anesthesia Coffee Break podcast where we try to make phys and pharm, palatable and relevant to, practical anesthesia. To get started, this is what I learned for opioids in the first part exam. And this is ridiculous, right? Like, we had to learn so much little amounts of knowledge, and a lot of it was really not something that was relevant. So what I really want to get out of all of these lessons is show you that this is the kind of information that we have to learn for an exam. And there's a lot of stuff out there, but if we find some critical points of difference between each of the medications and learn some, very crucial principles, we can use those principles then to apply to real life practice. And so what I'm going to do for you guys is to try and distill those points of any part of the pharmacology of each of these medications and then take it into a good clinical context. So that's my aim. I hope we all achieve that. So yep, there's a lot of minutiae and so much information for each drug, but this is really just useful for theoretical stuff, passing your part one exam. But in real life, a few crucial facts about each drug will guide the most of your decisions by far. So today's topic will actually be on local anesthetics. I want to cover the essentials of anesthesia meds in this series and other meds. I want to show you how this knowledge can help a junior doctor. Like obviously I'm, super specialized anesthetist, but let's go to using some of the important pieces of information, helping as a junior doctor, and get some real life examples to make you a gun intern. And that's what we're all about here. Local anesthetics, let's get started. These are some of the questions that I'll put to you guys. What local anesthetics are available for you to use? What injection site does toxic dose refer to and what the toxic doses are? What does percent mean? What is the CC to CNS ratio? What determines onset? What determines duration of action? And how do you do a Beers block, something you may have to do in emergency at some stage? What are the signs of toxicity? And how do you treat local anesthetic toxicity? Now, something that frustrated me in my medical school years, obviously this was a long time ago, was that I didn't feel like I felt like the stuff that I was learning in med school wasn't as practically useful as I could. So I'm going to take all of the super specialized knowledge I have, and some of these terms you'll never hear in med school, but they're super relevant. And potentially that's because, we think that maybe it could be a number of reasons, but I think that this stuff is really important. And I can take these super specialist principles and make them relevant to you. So let's start. Now, this is the stuff we're going to go through. What local anesthetics are there? The toxic dose, some special features, and what the CC to CNS ratio is. Plus, so we'll fill this table, which will be super relevant to you guys. I want you guys to now tell me what local anesthetics are available to you.
I know about lignocaine because.
Fantastic.
I just know.
No, that's the one that you most commonly will use. So, if there's any local anesthetic that back to front, lignocaine is the one. Okay, so that's really fair. Does anyone know any other local anesthetics?
I think I know one, but I'm not sure.
Go for it.
I know that, I don't know if it's used anymore, but I remember being taught that they used to put like cocaine in those tooth gel things for little babies. Does that count?
That does count. Cocaine is an ester local anesthetic. It's funny you mentioned that because cocaine has an amazing story, and I'm not going to go into it because it's just not something that you're going to use as medical students at all. Maybe once if you're working with ENT. Sigmund Freud had a big deal to do with cocaine and its use as a local anesthetic, which then transitioned to its use in ophthalmic anesthesia as well as spinals. I think this is the story. I hope one of you checks this out and corrects me if I'm wrong. When they found out that cocaine would also make you numb on mucous membranes as well as getting you high, so they this drug, they then injected into the spinal space, so the intrathecal space in your spinal cavity, and they would paralyze themselves just to see what the effect was. It is ridiculous what the story of cocaine is. And I'm sure there's medical books out there that show there's a number of ridiculous stories, but cocaine is definitely one of them. The other two that you'll use commonly is ropivacaine and bupivacaine. And so that's what we're really going to fill the table with. L-bupivacaine is like one of the isomers of bupivacaine. It's a less toxic isomer. You find that a lot of these medications, and you may have never heard of this unless you're in a chemistry major, but they are presented as isomers, and often one is more poisonous than the other. One often has the good effects and one has the bad. It's like having the evil twin and the good twin. So L-bupivacaine is just the good twin, and bupivacaine has a combination of both competing for safety and harm. Anyway, so we're going to go through that. Next thing is, what are the max doses of each of these? So bupivacaine has the lowest maximum dose because it is the most toxic. And finally, and ropivacaine and lignocaine are kind of the safest ones. So they have a high maximum dose, and lignocaine, you can get a really big dose if you combine it with adrenaline. So let's go through that now. By the way, the injecting location for these, so there's not a lot of great evidence for what these maximum doses are. You'll see some range in what people do, and the more senior you get, probably the more ballsy you get about what your maximum dose is. And so I'm not encouraging that, but I'm going to tell you this range because that's what you'll be really safe to do. And you won't seem like a cowboy. You won't seem like you're, doing stuff that's way out of the spectrum of normal. The injecting site is subcutaneous. So just remember, if I'm giving these maximum doses in something else like an intrapleural, epidural, spinal space, around any of the brachial plexus or other stuff that you probably won't do as a junior doctor, that will there'll be a lower dose. The reason for that is blood flow. With blood flow, it will take and extract the local anesthetic as it's going past that area, and then bring it back into the circulation so it can be toxic. So this is the subcutaneous maximum doses. Before we go into the actual maximum doses, what does percent mean? So if I was to tell you something is a 1% solution, that actually means nothing to us, right? Because unless we know how many milligrams that we're going to give someone, so therefore how much volume we're going to give someone, the fact that all of our vials are in percent isn't great. It does have in smaller writing how much total volume there is, and that's what we're going to we're going to get to. So 1 milligram per mil. What does percent mean in milligrams per mil?
I was thinking percent might be something like about 10 milligram per mil or something like that.
Hey, Tannis, did you know that already?
No, that was a guess.
That is a fantastic guess. 10. You're the first person in the history of me educating this to ever guess it right. So I'd give you a round of applause, and I'd love everyone else to give a round of applause, but no one except, we're not going to hear it. So here we go. X percent equals 10x milligrams per mil. It's fantastic. So there we go. I love the applause. You guys are so good at this. It's interesting because the way I see it is it's always in the worst direction. Like imagine if X was like 1% was 1 milligram per mil, that's actually favorable to me. It's always in the direction I don't want, because now I can't use as much volume of that. So now I want you to write down how many milligrams per mil for these amounts. You'd be surprised how many people don't know this, including interns, residents, and registrars and consultants who aren't anesthetics. And this to me is crucial information. So if I'm the first person to teach you this, look, I just want to plug every time you use it. 1% solution, how many milligrams per mil is it? And likewise for 2%, for 0.2%, how many milligrams per mil? Knowing that what Tannis said. Yeah, so 1% is 10. 2% is 20. 0.2% is
2.
And 0.3% is
3.
This is really easy. A lot of people don't know this. So if you're ahead of the game with this, that's amazing, okay? So here are the toxic doses. 3 milligrams per kilogram, 7 milligrams per kilogram with adrenaline, which is, a stark difference. So you'll be well within your rights to use 7 milligrams per kilogram if you're using lignocaine with adrenaline. Ropivacaine is 3, L-bupivacaine is 2.5, and bupivacaine is 2. So what I want to go through is some real practical stuff so you know when to use one or the other and how much volume you can use for each of these local anesthetics. how do you calculate the actual volume? Does anyone want to just tell me if you had a 70 kilogram person and you know the lignocaine toxic dose is 3 milligrams per kilogram, can some brave soul just step me through the process for calculating the maximum amount?
If it's 3 milligram per 1 kilo, you let it equal X over 70. And then cross multiply. So you get 210.
Beautiful. 70 times 3 milligrams per kilogram equals 210 milligrams total. Perfect. And how much volume then? If you've got a 1% solution, how much volume can you give this person?
It's 10 milligrams a mil, so it's just 21 mils, right?
That's exactly right. It is 21 mils. You know, it really is simple maths, right? 3 milligrams per kilogram times a 70 kilogram individual is 210. If you've got 10 milligrams per mil, that means 21 mils of that will give you is the maximum volume you can use. I want you guys to have a go at just calculating it with the rest. So this is one step harder, but I want you to know how to do this because this was something you will do time and time again in the emergency department. It's so practical. Write this formula down. If you're not great at maths, write this method down and store it away in Evernote or OneNote or your notes. Whatever you do, store this away because the first time you do this, you'll be like, what the hell am I doing? Especially if you're not good at maths, and your consultant or registrar will love you that you can actually do this. And if they love you, they'll give you a good reference. And if they give you a good reference, you'll get to be in the training program you want to be in. So this is all part of that.
I can maybe try the first 3.
Please do.
So I think we said 21 for the 1%.
Yes.
Would the 2% just be double? So 42? Or it doesn't work like that?
It'll be half, yeah. Because it's more concentrated. So you divide 210 by 20 milligrams per mil. 210 divided by 20.
Because it's the 10x, it's 20.
Exactly, yeah, that's right. And you know that 2% is stronger, right? So you have more molecules in 2% than 1%. So you can't use as much volume if it's more concentrated. Yeah. That's good.
So 10.5.
Yeah, 10.5 is right. So 10.5 mils total for lignocaine, 2%. How about lignocaine 1% with adrenaline? 7 milligrams per kilogram.
49 mil.
Exactly. Step out, you're working for us, Tanis.
Because with lignocaine, it goes to being 7%. It goes to being 7 milligrams per mil. 7 milligrams per kilogram. So it becomes a maximum dose of 490 milligrams.
Fantastic.
Total,
490 milligrams.
49 mil.
Beautiful. And then, so that's 490 divided by 10 equals 49. Fantastic. No one's going to do this maths for you, right? You've got to do it on the day when you're injecting that local anesthetic. And luckily, with lignocaine 1% with adrenaline, you're rarely going to go, like if you're doing what you're doing in emergency as an intern, which is, suturing lacerations, chances are, unless you've done something horribly wrong, you're not going to be giving 49 mils. So that's a really safe agent to use in most situations. Ropivacaine and bupivacaine?
Is it 70 kilograms times, since the max dose is 3 milligrams per kilogram,
yes.
and then you divide it by
yes.
7.5
yes.
milligrams per milliliter, so you get 28.
Absolutely. Yeah, that's right. And so what's interesting about this, so I hope everyone heard that. With ropivacaine, max dose is 3 milligrams per kilogram, so it's 210, just like before, and you divide by 7.5, because that's 7.5 milligrams per mil. So you get 28 mils. Interestingly, bupivacaine 0.5%, these are the common solutions that you'll see around. It's 2 milligrams per kilogram as the toxic dose. So that's 140 milligrams total divided by 5, which also equals 28 mils. So I often you won't necessarily often have to give ropivacaine and bupivacaine, but the shortcut I do is because they always end up the same amount as long as they're the 0.75 and 0.5% solutions. I just times by 0.4 mils. Now I didn't want this to become a maths lesson, obviously, but these are just a few of the little tips little tips and tricks that I've learned for this. Now, someone might rarely want you to combine local anesthetics. So the question is, what do you do if someone wants you to give lignocaine and bupivacaine at the same time for, you know, for different body parts or for whatever reason? There's a lot of contention about what to do about this, but it gets more complicated. So I really just add the maximum doses of each. So they're summative. So I give half the maximum dose of lignocaine and half the maximum dose of bupivacaine. I won't go into that, but that's just to let you know the extra complexity that could happen. It's not difficult to understand. And the situation might arise. Fantastic. Any questions before we move on? That is the bread and butter of what you may have to calculate around local anesthetics.
This was
please.
ages ago, but I missed it and just want to write it down.
Yeah.
When you said the maximum doses refer to the doses used subcutaneously, and you mentioned in some other area you need to use a lower dose because of the blood flow. Where were those areas again?
Yeah, so if you imagine the context that you use local anesthetic in are pretty standard. These contexts are like regional anesthesia blocks. Commonly the ones you'll see will be femoral nerve and fascia iliaca blocks, FASHIA, iliaca ILIACA. Again, this will actually be in some of the slides, so don't worry too much. And things like epidurals. It's a very vascular area. And maybe even if you were to do local anesthetic around the scalp, a very vascular area. As you get onto your training, you'll start putting needles in the necks for central line insertions and other kind of procedures. And that's also going to be high risk. And just know that if you're doing subcutaneous procedures, so lacerations, fingers, face, anywhere else in the body, this is completely fine for that. But just to be aware that any other situation that's not the most straightforward, just probably ask your ED consultant, which is probably that's probably when you're going to be asked to do it. So that goes on to ask, where could even a small dose of lignocaine cause lethal consequences? And hopefully you never see this, but just remember that as you get more senior in your career, and a lot of training registrars may not know this. So I want to teach you guys the stuff that I know now, even years and years down the track, that even 1 mil of 1%, 10 milligrams that injected into the carotid artery or a vertebral artery, that this could cause coma, apnea, or even cardiac arrest. That's how serious this stuff is. I've just told you that 3 milligrams per kilogram is completely fine, but now I'm telling you that if you're doing a central line or some kind of neck kind of case, if you were to put it into the wrong spot, like a central vein, a carotid artery or the vertebral artery, so it goes straight into the brain. There's no dilution in the whole body. It's not like the body slowly brings that local anesthetic back through the venous system. It dilutes out, and then the heart receives the local anesthetic, and it then goes to all of the body. This carotid accidental injection goes straight into the brain, and then it will cause its effects because of a very high concentration at this effect site. Just want to give you that, because that could potentially be one of the things you do in the next 10 years that could be really bad. So when I inject, I do something very specific as I'm injecting to prevent intra-arterial or intravenous injection. You'll learn as you're doing these injections. Again, another practice point: when you put the needle into the skin, you aspirate on the syringe, so you pull back on the syringe gently, and if you're in a vessel, you'll get blood flow back. And the first time you do that, you'll be like, oh, thank goodness I aspirated, because I was just about to inject into a vessel of some sort. So that's just one of those really crucial practice points. This will become second nature to you as you start your medical practice, but it's just something everyone does to prevent any problems. What is the CC to CNS ratio? Just shake your head if you're not sure what this is. Does anyone know what this is? That's good. Okay, this is one of those things I love doing. Obviously I've been studying anesthesia for just too long, and I wish I knew this as a medical student and as an intern, because this really matters to me. The CC to CNS ratio it's called the cardiovascular collapse to central nervous system effect ratio. So that it's the toxicity of local anesthetics. They can be compared using this ratio, because the ratio of the dose causing cardiovascular collapse to the ratio of the dose causing the CNS signs and symptoms gives you a number. So if that number is really low, it's super lethal. And imagine what that means. It means that if I've got a really big ratio, that means I'm going to get a certain amount of anesthetic, might give some CNS or central nervous system symptoms, but it will take a far bigger concentration or dose to give me cardiovascular collapse. So my ratio will be really high. So low is lethal. And you'll find that these are the ratios. So lignocaine is really large. It's super safe to give. You'll see people giving lignocaine intravenously because it's so safe. Ropivacaine is 5, L-bupivacaine is 5, and bupivacaine is 3. So roughly a toxicity is bupivacaine is super toxic. These ones aren't exactly safe, but they're less toxic than bupivacaine. And then lignocaine is very safe. That's why most of the time we'll be injecting lignocaine for most of those cases. Here's a rough table of the main points of difference that I use when I'm choosing these different agents. Remember that first big table that was really messy with lots of stuff? This is a synthesis of that table. This is all I feel I need to know to practice really safely. And the other stuff's important, but I reckon these rules, these rough points of difference will help you in your decision. So lignocaine's fast onset. You can use large volumes because it's not very toxic and it's short acting. So the effect is gone quickly. And sometimes you don't want the effect to last for ages. All the others are relatively slow onset and they're longer duration. So in the practice of, doing little lesions, any kind of lacerations, which you'll be doing commonly, you don't really need ropivacaine or L-bupivacaine or bupivacaine. Finally, there's a thought that maybe bupivacaine is the most effective. And part of that balance is if it's the most effective, it's also going to be the most toxic. Because the funny thing is the reason anesthetics work is they block sodium channels, which are on nerves. The way they affect it is sodium channel blockage, but there's also sodium channels in all other parts of the body. So if you have sodium channels in the heart, for example, the most effective anesthetics and the ones that are long duration will attach those sodium channels on cardiomyocytes, and they will stop the depolarization of these cells or cause problems with that. So bupivacaine is fantastically effective, but it is horrendously toxic. Which local anesthetic we'll use most of the time? So really it's lignocaine. Lignocaine is the one you'll use time and time again. And really it's for these small lacerations in the emergency department, maybe even in plastics. As you get a bit more senior, as you become a resident, they'll need you to do small procedures. You'll be using lignocaine constantly. If you're in a general practice, you'll be using for moles, skin lesions, any excision of those things. And it really is safe with low toxicity and all purpose. So, if you remember any formulas, use it for lignocaine with and without adrenaline, because that will be your bread and butter of what you do as a junior doctor. So when would you use lignocaine with adrenaline? Really, it's when you want large volumes. Having 49 mils in a 70 kilogram person means that you can really inject lots of sites. Sometimes you'll get patients with multiple lacerations. Imagine you're in an emergency, someone comes in, they've gone through glass, or maybe they've been sadly assaulted, and you might have to suture up a number of different lesions, a number of sites. So you need large volumes. Lignocaine with adrenaline is great for that. And sometimes in vascular areas, you want that adrenaline to constrict your vasculature. And so I'd also use adrenaline in those situations. If you constrict your vasculature, it means that your dose, just like in those other things we mentioned just before, if I inject in the epidural space or the brachial plexus blocks and other places with more blood flow, adrenaline just clamps that down and allows my local anesthetic to last very much longer as well. And then when would you use lignocaine without adrenaline? I don't know if you guys have ever heard, but if you have peripheral sites, there's a thought that because adrenaline vasoconstricts, if you inject it at any kind of terminal points in your body, including your finger, that might constrict the arteries and cause severe ischemia. So generally speaking, especially as an intern, you'd probably never use lignocaine with adrenaline at peripheral sites. There's definitely some people who do, but that's definitely not for you as a junior doctor or medical student to do. And I imagine as you become more senior in your clinical placements, you'll be definitely injecting local anesthetic and doing suturing as part of your training. There's also a thought that, adrenaline could be reabsorbed into the body, and adrenaline, while it's great for resuscitation in many ways, it's also can be arrhythmogenic and cause cardiac irritability. So maybe some really, really frail patients, you want to ask your boss and say, hey, is it okay to use lignocaine with adrenaline? And then some people might have malignant hypertensive disorders, such as preeclampsia or something else going on.
CC on CNS ratio, is that the dose that causes cardiac symptoms divided by the toxic dose.
Yeah, that's right. The dose that causes cardiovascular collapse, so let's say cardiovascular arrest, versus the dose that gives some kind of neurological symptoms, which we'll go through. This is really important because when you imagine what's occurring as you've given an anesthetic or you've given the local anesthetic into the skin, and then maybe the patient complains of something that's a CNS symptom, then you know that maybe if this was a more toxic agent, that it's now absorbed enough to cause a rise in your blood levels to cause CNS symptoms, and how much more is it going to rise in the next few minutes, half an hour, and then you might want to do something about it. As we mentioned briefly before, when would you use ropivacaine? Really long-lasting block analgesia. So, epidurals, paravertebrals, fascio-iliaca blocks, wound catheters. And as you're in your surgical rotations, you'll see me and my colleagues and the surgeons, doing these techniques, and you'll see ropivacaine and bupivacaine used. As an intern, as a resident, you want to know that this is the agent that's been used. And just know that there's many ways that this can go wrong. Like a lot of M&M, a lot of morbidity and mortality occurs because of regional catheters, and so many systems are now in place from errors in the past because we need to improve these systems. Now, one of the horrendous things that you may see in your career, and I hope you never see this, is that the wound catheters are the same Luer lock connection, so the same connector for these catheters that run into the tissue are the same as the ones for intravenous use. So very rarely, you hear stories about this. Unfortunately, I've never seen this happen in my practice, but there've been reports of it happening, is that maybe someone connects the wrong line to the wrong site. Imagine what that would do, connecting a regional infusion of ropivacaine or bupivacaine intravenously. That would be a disaster. It would be a sentinel event. You'd have investigations and everything. So that knowledge is important to you. Knowing that someone is on, infusion of bupivacaine for a paravertebral and epidural, maybe on the labor ward and they're on some kind of infusion, and maybe they're running a really high dose of it. That would be something to look at and you go, well, isn't this dose seems really high? Why are we doing that? And because there might be a programming error. Just know that people are fallible. And this kind of stuff is so important that you know exactly, what the dosing is. And then if there's a problem, you just ask the question upwards, ask your boss, ask the head nurse, and they'll be able to check it for you as well. Bupivacaine, when would you use that? Literally the same situations. You want really effective analgesia and you want it to last a long time. Just know that you have to use less of it. Okay, in the last 15 minutes, I thought we'd get into some theory and then talk about the resuscitation stuff as well. So what determines duration of action and what determines speed of onset? This is a bit of, the theory that I had to learn, and I'll just go through it because it's a certain amount of relevance, because I think knowing this peripheral information probably is useful. Duration is all about protein binding and also a bit about vascularity. So know that bupivacaine and ropivacaine are really highly protein bound, like 95% protein bound, and lignocaine is generally low, about 70%. So lignocaine doesn't really bind hard to those proteins to stop sodium transmission or nerve conduction, but the ropivacaine and bupivacaine do. So that's one of those specific pharmacokinetic type things that are really important. Onset is just as interesting. It's all about pKa. Now, pKa, I was normally going to ask you what pKa is, but it really isn't too important for you to know definitions at this stage. We had to go through a lot of it in anesthetic training. It's, simplistically for our purposes, pH is so pKa is the pH at which the substance is 50% unionized and ionized. And I'm sure as soon as I said pKa or unionized, half of you fell asleep, and that's really fair. But, give me this. It makes me sound smart. It will make you sound smart as well. The unionized portion doesn't have a charge, so it crosses lipid membranes like the phospholipid membrane on the nerve far better than ionized portions. And so you want more unionized fractions. So if you ever want to have a chat with this about anesthetists, they'll love you for it. Now, most of your anesthetic agents, most of your drugs are weak bases. So the lower the pKa, the more unionized fraction there is, so you'll have a faster onset. So the pKa of your local anesthetics, lignocaine is about 7.9%, and ropivacaine and bupivacaine are 8.1. And so that's why you'll have a faster onset with lignocaine than the other two. And you'll notice this as well. it's really due to a few other factors, such as the amount of drug you're giving, the concentration, the gradient, the amount of thickness of the barrier. So anything that's Fick's law of diffusion. Again, don't worry too much about that. Once you start hearing Fick's law, you know you're sitting the anesthetic primary exam. Now, knowing what you know about that. So I've just told you that the pKa, it works better. So if the lower the pKa, the faster something onsets. Now, the extra thing to this is that if some place is very acidic, it won't work very fast. There'll be far more ionized than unionized. You'll be taking care of general surgery patients with abscesses, and abscesses are notoriously acidic environments. And you'll find that, I hope this never happens to you where, you get asked to see a patient in pain who needs an incision and drainage of an abscess. And often you can just do an incision and it's, it's small, it's fine. But if you try to inject local anesthetic around the direct tissue near it, it just won't work as fast as you need it to work. Don't take my word for it, but actually maybe you should take my word for it and don't try and get assistance at that point. But if you're ever puzzled as to why your local anesthetic isn't working, just consider what I'm treating here. Maybe there's an infection and a lot of pus and a lot of anaerobic metabolism causing lactic acid in that microenvironment, and that's causing problems with the anesthetic working because there's too much ionized fraction. Has anyone seen a Beers block? And does anyone know what it is? No, that's right. I'm really excited for you guys because you're at the start of your medical career. I'm really hoping this is all the stuff that I wish I'd learnt straight away, or at least been given the resources. Now, I tell all my students, it's not a matter of knowing stuff. It's often knowing where to know stuff. You'll naturally memorize the common things you do because it's common. You'll repeat it hundreds of times, and you've got to memorize emergencies that don't leave you time to find a resource. So those are the two things I encourage everyone to memorize stuff for. Now, the rest of it is knowing how to access knowledge. And, data is the new religion, right? So data is everywhere, and we just know how to get good data and go through the good data. So I'm going to tell you that the Royal Children's Hospital site is fantastic for not just children's stuff, because they have guidelines on everything from fluids to managing lots of, pediatric as well as adult problems. So if you were to just search beer block, RCH, in fact, everyone do that now. And I want you to bookmark this site as one of the resources that I just highly encourage will make your life very, very much easier. Again, impress your bosses, treat your patients well, get your training program. Now, just to quickly, I won't go through the whole procedure, but I want to give you as much information as I can because I used to hate it when people talk down to me as a med student and just gave me little bits of information because none of this is difficult. You just got to know where to find it and you just got to know it. You just need exposure because none of it's like, quantum level physics where, no one really understands. So here we go. What local should you use and why?
Lignocaine.
Yeah, lignocaine. Why, Amy? So to me, I think, it's the safest drug and you can use a decent dose of it for fast onset. So yep, lignocaine is right. It's the safest one. If you ever gave ropivacaine or bupivacaine intravenously, you're doing something wrong. That's like a lethal injection, okay? So the severity, the seriousness of using ropivacaine and bupivacaine intravenously is that your patient could die. And that's just not a joke. That will happen if you give ropivacaine intravenously. Lignocaine is far safer in the right system and format. Just remember, this is still very full on. You're giving local anesthetic intravenously. It is remarkably toxic. And so you'd have to have everything ready to sort things out. So for example, you'd manage the whole system. You'd have monitoring to check for cardiac dysrhythmias. You'd have all the resuscitation equipment around. You'd have appropriate staffing and have staff able to manage an airway, breathing, and circulation. And you'd have all the treatments for local anesthetic toxicity as well, which we'll go through. What dose? So really it's 3 milligrams per kilogram, and you dilute maybe a 1% solution to make 0.5%. And they talk about having a max volume of about 40 mils. There's a few systems in this. For example, you would have a few things there like, exsanguinating the arm, having a tourniquet, maybe even a double tourniquet. And what do you reckon? Oh, sorry, I've already gone through the answer, but you prevent systemic spread by having a tourniquet, maybe even a double tourniquet system can be used. So you can, go from one tourniquet to the next, depending on what you need for that. Also, you have to get it above arterial pressure. So you might have, about 75 millimeters mercury above your systolic blood pressure. I don't try to remember these, by the way. If you do it a lot, you'll know it. But otherwise, I just go to that website and just checklist everything so I don't forget a thing. just remember that, no one can remember complex stuff, multi-step stuff. You'll all forget something, especially if you don't do it commonly. I want someone to tell me, where do you place the cannula? Let's say I'm doing a Beers block for reduction of a Colles fracture. Where would I place the cannula?
Maybe in the hand. I don't know.
Yeah, Tilly, you're absolutely right. It's in the hand. And this is a really tough question. I'll give you a go at it. If I've got a tourniquet here at the upper arm, the arm, and I put a cannula at the cubital fossa, why is that a problem? By the way, that's the way I'm injecting my local anesthetic into the cannula. Why is that a problem? Whereas injecting distally isn't a problem. They don't highlight this as a problem in that document, so I thought I'd tell you all now. So, I hope no one ever sees this done. When you have a syringe, the pressure you can deliver with that syringe is quite an incredibly large pressure. So if your cannula is here, that pressure of injection can go underneath the tourniquet and make it go systemically. So that's a horrendous problem that you don't want to have. And that's why you need to place the cannula distally, okay? So just a really big error that can be made, and that has happened in the past. So it's distal that you must place it, not in cubital fossa. And then you also put one in the other arm. One is for giving the injection of local anesthetic. The other one is for other medications, sedation, resuscitation, as you might need to do it. Now, that was me just going through the principles of a beer block, but also going through some of the pitfalls and some of the reasons why. Because that's definitely one of the things you will see during your ED terms as a junior doctor, and maybe as a medical student as well. And I'm really hoping that you prevent some crazy M&M occurring because of your knowledge of this. There's been cases in the past where someone's given L-bupivacaine. That has actually happened, and you'll be the one to stop that because you've got this information. Another time there'll be someone who, people have put it in the cubital fossa, and that has happened, and you'll be the one that can say, hey, are you sure that should be done? Most importantly, how does this go very wrong? What are the signs? So the early clinical features, just remember this, the relevance of this, it's anything that can be neurological. So tinnitus, difficulty with visual focus, dizziness, lightheadedness, agitation, confusion, perioral numbness, metallic taste, anything that's a little bit weird it's the head space, that's something you need to watch out for. That itself will not cause harm, but as the local anesthetic rises in the blood, maybe that will be the first indicator. That's a canary in the coal mine of something really bad happening. So just remember this, you'll be somewhere on the maybe maternity ward, and maybe the patient's got an epidural, or maybe it's a surgical ward, they got a paravertebral with an infusion going, or maybe you were injecting an anesthetic while doing procedure for something. The patient says, wow, that's weird, or they start talking about something irrelevant, or they say, wow, ringing my ears, tingling around my lips, why is that happening? Why am I tasting something funny? I want that to trigger something in you that goes, hey, let's call for help. This is not good. This patient's now having CNS symptoms, and this can now progress to what we would really, really not want to happen, which is seizures and coma, bradycardia, hypotension, ventricular dysrhythmias, conduction blocks, and eventually cardiac arrest or respiratory arrest. So again, crucial information that we should teach every medical student, because this is real. Like, this could really happen, and it happens. One of the great reasons why I'm putting this up on YouTube is that I only learned this stuff as an anesthetic registrar, and it's so relevant, right? And if it's on YouTube, it has an amazing reach to people with not the same education that we have, through Melbourne Uni or Monash or Notre Dame or any of the other universities. So finally, the way we treat this is like we treat any other sick patient problem. It's a doctor's ABCDE approach. And I'm potentially going to teach you that in another section, or someone else will teach you that during your time. But there's a couple of really important things that, again, it's just knowledge, and it's pretty easy to know. There's some low evidence, so not great evidence, to suggest that intralipid, 20% boluses and infusions will be part of the solution. So you do all your normal resuscitation and you send someone out to get intralipid. And on the ward, they won't know what that is necessarily. So then you call the anesthetist in charge and say, hey, I think I might have local anesthetic toxicity, and your anesthetist will rapidly get up from their Sudoku puzzle or their crossword puzzle and come and help you out. Like, it will happen very quickly, and they'll thank you for it, because that's just something that we love resuscitating, so we'll enjoy that. So that's one absolute crucial thing with treatment, and also prolonged resus can be a problem. So imagine that sodium channel is blocked really tightly by bupivacaine, and you've got a young patient, a pregnant patient who's arrested, you don't stop the arrest in this situation. So sometimes you might have an elderly patient and you'll have certain, limitations of treatment, but just know that this is a situation that you might have to call for ECMO. Does anyone know what ECMO is before I just keep talking about that? Yeah, so ECMO is extracorporeal membranous oxygenation. It's really just cardiac bypass, but in a more portable fashion. That sounds intense, right? Imagine you as an intern, even a medical student, telling your consultant, hey, I suspect that there's going to be a prolonged resus. We should probably call the ECMO team. Not only will you get a amazing reference, but you could save the life of this patient, because calling that team from the Alfred Hospital or RMH means they'll rapidly come over to this young patient, or you'll make the referral. They'll assess over the phone whether this is worthwhile, and they'll come over and have to plug that patient in. But this can all happen within an hour. So you can resuscitate for an hour, and then they'll plug this patient in, and they'll be able to keep the heart and lungs of this patient going through this bypass type circuit and keep them alive while you treat all the other stuff happening. Just one extra little thing that I thought would be really worthwhile knowing, because again, I had to be pretty much an advanced training in anesthesia before I learned this stuff. Any questions about that pretty high level stuff?
So in a young, fit, healthy person who potentially has the local anesthesia toxicity, you wouldn't be expecting a prolonged resus. It's more those complicated patients.
Oh, actually, it's any patient who's had local anesthetic toxicity, which is usually going to be ropivacaine and bupivacaine toxicity, they will all potentially have a prolonged resus. In my mind, as soon as I have any inkling of that happening, I'm getting someone else, I'm offloading the task for someone else to call for the ECMO retrieval service to see if that's a valid indication for it. I'm not an ECMO expert, so I'd offload that task to someone else to just sort out while I'm doing what's really important at hand. But that's a great question. Any local anesthetic toxicity situation where they've arrested may need ECMO. And that's what intralipid looks like. It can come in a bag or a bottle like this, just to know. But if you were to call the anaesthetist for that, that would be a very good thing. And again, this is pretty recent in terms of the last 5 or so years, 10 years, in terms of this kind of evidence. Guys, that's all I really wanted to go through. And that's probably a good hour. So local anesthetics done. Here's the summary. Local anesthetics, the main ones we've gone through: lignocaine, bupivacaine, and ropivacaine. Percentage means 1% is 10 milligrams per mil. CC to CNS ratio is an indication of toxicity. Lignocaine is very safe. The others aren't as safe. What determines onset really is that PKA business. Duration is protein binding and vascularity. How do you do a Beers block? Right, we went through some of the real pitfalls that you may see. What are the signs of toxicity, and how do you treat LA toxicity, especially these extra little points that sometimes your seniors may not even know about. So again, it's just knowledge. Now you know it.
Lahiri, thank you for the lecture.
Thanks very much for that.
Thank you.
Guys, have a good afternoon.